We're going to get started in just a second, so thank you very much. And welcome to everybody in the room towards the end of the conference. We've got about 100 people here, and also some folks who are tuning in from the webcast as we aim to wrap up what I think has been a successful conference. And we'll get started now looking ahead and everything that everybody can think about as they head off to their various airports and across the city. So I'm Louise Radnofsky. I'm a health policy reporter with the Wall Street Journal, and I'm excited to be here, partly because the Work Support Strategies program has been something that's been very interesting to me. Obviously, I'm required to say that as a reporter, I don't have an opinion on whether it's good or bad, but I certainly have an opinion on it being very interesting, and something that Olivia has pitched me on as the subject of the story and invited me here, and I'm excited to be here to learn more about it. You, of course, and folks tuning in know a lot about it already, so this session is really aimed at looking at the next steps, what happens now, especially since in the wake of the King v. Burwell decision, as we know, the Affordable Care Act is here to stay, at least for now. And in my case, I've covered health policy since October 2011, so I've covered primarily, almost exclusively, in fact, the Affordable Care Act through its implementation in the regulatory phase and its rollout through the fall of 2013, in which I think I was probably in my house about as frequently as administration officials were in theirs. And that was a rough time for various reasons for everybody. And then, of course, through 2 Supreme Court decisions as well. Both of which have had significant impact on the work that you've been doing and in the States. For now, at least, there are no significant legal challenges to the health law, so the next remaining step in determining its future is the 2016 election. That gives you 18 months of breathing room to really stop and think about what you want to see happen next, and so now is an excellent moment to reflect on that. So we have a terrific panel here to help us do that as we look at next steps for health and human services integration. To my left, we've got Dr. Maria Cancian from the Administration for Children and Families. Dr. Cancian's the Deputy Assistant Secretary for Policy, and she's not Mark Greenberg, as you've noticed, but knows, as I understand it, as much as he does, if not more.
Nobody knows as much as Mark does.
On this particular area. To my right, we've got Judy Solomon, who's the Vice President for Health Policy at the Center on Budget and Policy Priorities, and probably needs no introduction to many of you here. Equally, Jen Wagner probably needs no introduction. Jen agreed to fill in on this panel for Chet Hewitt at 2 seconds' notice when asked by Olivia last night, and immediately bowled me and everybody else over with how much she knew about this subject, so we're thrilled to have her here, even if we're sorry we can't have Mr. Hewitt. And of course, Olivia, all of you know already. So she certainly needs no introduction, but she's certainly been, for me, somebody whose opinions on welfare policy in particular have been very influential to the extent that welfare policy has got a look in at all in the last 4 years, and one of a variety of people I consider to be part of a very strong brains trust on that. So I appreciate it, and I'm very glad to be here for that reason. I think I'm going to stop talking and turn this over to everybody to actually introduce themselves in more detail and to explain a little bit about where they see this subject going and what the next steps are. And so with that, I will, in fact, turn over immediately to Dr. Cancian. Oh, except that I'm supposed to tell you that we will, after everybody has introduced themselves, have a bit of a conversation, then we'll throw it open to some questions. I'll have some, but I suspect that everybody in the room, some of whom I probably know from the telephone, or from email, and do come up and say hello afterwards, because it's a lovely part of the job to get to meet people from across all the states, but you never get to put faces to those names, so that'll be nice. But you will have far more expertise, so please feel free to contribute your questions. I think there'll be some walking mics around for you to do that. But for folks who are tuning in on the webcast, you can email your questions in at events@clasp.org, and somebody will bring them to the table as well. So please do that. I'll remind the email address again when we get to the question phase. But for now, I'll turn over to Maria.
Good morning. Now, do I have to do anything, or it's all set? So it's a pleasure to be here. I'm sorry I wasn't able to be here for the rest of this conference. I was in Kansas City, and I think I learned that I was going to be here this morning, maybe an hour before Jennifer did. But it's an opportunity for me, because while I absolutely would never claim to know as much about Mark as Mark, about most things. I have been spending the past year working largely on program integration and interoperability, so it's a real pleasure to be able to come and chat with you a little bit about that. As most of you know, ACF has a responsibility, the federal responsibility, for many programs serving low-income populations, including child welfare, TANF, Head Start, child care, runaway and homeless youth, so a range of programs. And the opportunities presented by the ACA are really huge and cut across virtually all of our programs. And as I don't need to tell you how much of an impact it's had in terms of insurability, so I'll kind of skip those points and talk a little bit about what we see as the implications for our programs now and going forward. So, one big piece of this, which I will not spend as much time on, is that the focus on insurance and care has really highlighted the social determinants of health, and I think has refocused people on the potential value of human services in kind of prevention and providing a context where healthcare can work. I think another piece that we've kind of the flip side of that coin that has really been a focus is it's really created opportunities for us to better serve the populations that we serve in our programs. So like just one example that I would give you is in the area of health, mental health, and health parity. We know, for example, from our research on the populations we serve that both mothers and fathers in our programs are disproportionately likely to suffer from depression and to not have effective treatment for depression. For example, in a recent study of related to our Healthy Marriages and Fatherhood program, more than 1 in 4 of the fathers in the program reported severe depressive symptoms that affected both their ability to work and their ability to parent. And because depression is treatable with appropriate access, but because so many fathers don't have and haven't had access to that treatment, the ACA opens new opportunities for us to be able to kind of manage those issues and be able to better serve fathers and have fathers play a stronger role in the lives of their children. I think overall, I think the ACA provides opportunities for a lot of what I would call upstream interventions that might, in some sense, make some of our services, whether it's in child welfare, homeless youth, domestic violence, less necessary if people are getting the services that they need in health and mental health. Now, as part, there are lots of opportunities. I think we'll also be able to have a chance to talk about some of the challenges that have come with ACA implementation for human service providers. That includes the fact that we have limited bandwidth, that not everything is health, that human services are valuable for lots of reasons, including their ability to improve the context and reduce health needs. But they are also important in their own rights. And sometimes if we only have a health lens, that also gives us some challenges. But I'll focus a little bit first on some of the other opportunities. We have really been focusing at ACF on opportunities for better service integration, and in particular on the systems side for interoperability. And I think there's at least 4 motivations for that. One is that we recognize that a lot of the populations that are most in need of services are not in a good position to manage sometimes very complex and burdensome enrollment and eligibility and re-enrollment processes. And we're very motivated to try to improve those processes to help people get the services that they need. I think a second motivation is that given the sustained need to do more with less, I mean, I hope we'll get good budget news, but I'm not betting a whole lot on that. Given the sustained need to do more with less, we really need to be able to better coordinate the services that we're able to provide, because we just can't afford either duplication or lack of coordination given resource constraints. I think a third piece is that our stakeholders are demanding that we be more accountable both for our inputs and for being able to talk about what the outcomes related to those inputs are. And interoperable systems and better integrated systems give us an ability to use data more effectively, both for performance management, for accountability, and actually to better inform policy development. And so all of those different people have a different emphasis on pieces of that, but all of those can be served by more integrated systems and information. And fundamentally, that integration allows us to have family-centered services as opposed to siloed services. One of the things, I have an opportunity in this role and in my previous work to meet with lots of families that are served by our program, and one of the things that I often say is I've never met a family who's introduced themselves to me as a child welfare family, or a TANF family, or a SNAP family. They are families with a set of resources and a set of constraints that they're trying to manage, and generally if they are depending or relying on one of our programs, they are engaged in more than one of our programs, and they expect and need to be treated as a family, and our systems need to relate to them as a family, not as a participant in an individual system. So all of this is a good reason to work on integration. ACF is doing a number of things to try to push that agenda forward. I believe you heard from some of my colleagues in FNS and CMS recently. You heard about our efforts to promote the use of the AAD7 waiver. The improved financing options really do, and the 3-year extension, we hope really do create an opportunity for states to move beyond, not to put aside, of course, ACA implementation, but to take a breather and to take a step back and say, how do we build on ACA, and how do we create a more integrated system that can really serve the needs of our clients? In addition to the improved match, we have a kind of new data and APD for those of you who are in the business, and systems sharing space for states, which will roll out this month. We also have added new staff at ACF. We have a new senior advisor for data sharing, and some new staff who will be working both across ACF to facilitate the work that we're doing to share data, and also working with our state, tribal, and local partners to try to understand better what you all need and what we can do to be helpful. Just to give you a couple of specific examples, we have been working on some model data sharing agreements. We have been working on some Dear Colleague letters that will clarify the scope of permissible data sharing across programs, because I know from working at the state level that we often worry that we can't talk to one another because the feds will get mad at us. Sometimes that's true, but often people perceive there to be more barriers than there really are. And we're also working on other technical assistance and resources that can help promote state efforts to combine data and use data to both support better program access and data analytics. So I think I'm probably out of time. So I'll just say that we look forward to working with our state, local, and tribal partners. This really is a challenge for us within ACF to work across our programs and get our coordination, to work with our colleagues elsewhere in HHS and beyond HHS. And again, the goal here is to provide to design our programs and policies and to present a face to our clients that really recognizes a family and the things that we need to do to support those families and individuals in moving forward.
Thank you, and I think we'll come back to a couple of those points, if not more, shortly. I'll turn to Judy to make a few remarks. Judy is, as you all probably know, one of the Medicaid and CHIP experts out there in particular, which is the context in which I know her, although I think she has an array of interests as well, and perhaps a sense of how they all fit together in this sense.
Thanks, Louise, and thanks. I'm really happy to be on this panel and excited to hear the questions especially. So when I was thinking about coming here and what the next steps were, I remembered the day after the King decision. And I was sitting in my office doing my work, and all of a sudden I said, wow, what would I have been doing if it had gone the other way? And I realized that the real gift was that I could keep doing the work of moving forward, that we all could do the work of moving forward instead of sort of frantically trying to figure out what are we going to do to keep those millions of people from losing coverage. So it was really, really exciting to be able to think about how do we move forward to get people health coverage, health services, and then make those connections to all of the other programs. And I think that's really what our focus is here in this conference, but for many of us in the work we're doing. And I think for the health team and the larger advocacy community, I think there's really three things that we need to focus on, three big things. They're not small. And the very first one, I think, is to get more states, and all states eventually, to expand the Medicaid program. Because I think that is critical to this integration of health and human services we're talking about. There's still 4 million uninsured, very low-income adults who are in the coverage gap. And it's staggering to know that 89% of them live in southern states. And no surprise, because they live in southern states, more than half are people of color. And until we can sort of move the needle on those states, it's going to be really hard to get success on connecting health and human services, behavioral health services, and other services if we don't have that first step of getting people covered. And so part of that is also making sure that when we do that, we don't do it in a way that undermines the essential beneficiary protections in the Medicaid program. And here I'm talking about the waivers. We all call them waivers, but they're really supposed to be demonstration projects, demonstrating things that pursue the objectives of the Medicaid statute. So, one of the big things is states want to charge people, they want to do work requirements, they want to do time limits, and it's really critical that we maintain those lines. We know that premiums and cost sharing keep people from getting health care. There's nothing to demonstrate. It's a healthcare program. There's no reason for work requirements. So we need the expansion, but we also need to make sure that it's done in the way that doesn't undermine the end goal of getting people health care. So the second thing after that is really related to what we've been talking to over the last few days and working so hard on in work support, and that is continuing the work to streamline the eligibility and enrollment process so that it's integrated horizontally with other programs that family need. But I think the other part of it is to make sure that there's that vertical integration as well. The challenge of coordinating Medicaid, CHIP, with the subsidy programs, particularly in the states, the vast majority using the federal marketplace, is huge. And there is a ton of work to be doing on that. I think we're at, when I was talking to some of my Medicaid colleagues last night, and I said, for someone who has spent decades working on Medicaid, starting when, the notices were handwritten, that's how old I am, it feels like in many of the things that we're working on particularly in the federal marketplace, is we're still at that sort of ground level of establishing a service of consumers and explaining things to them in a way that works. So a ton of work to do there, coordination. It's hard, but you've all been doing it on the horizontal side, and needs to be done on the vertical. And then the third, and this is where I am really, really excited, because I think, we're all sort of talking about this, and there's so much going on and so many new opportunities, is the development of new strategies and improvement of existing strategies to integrate the delivery and financing of healthcare with other human services programs. And here we're talking really going beyond the systems and the processes that you've all worked so hard, and really bringing that same kind of energy and that same kind of work of nitty-gritty program integration with the actual delivery of the services. And I think it's a very similar kinds of things that has to happen. The ACA really opens new doors, and the Medicaid statute already had a lot of opportunities for ways that states can deliver better coordinated care and reform their health care delivery systems to better integrate with human services. For example, states can use Medicaid funds to pay for some housing-related activities, particularly for people with disabilities and people who are chronically homeless. States can also offer supportive employment programs through their Medicaid programs to people with severe mental illness and substance use disorders. And then, of course, there's the whole area of criminal justice and the ability to connect people when they're leaving prison and jail, and in some cases even keep them from being incarcerated in the first place by improving the delivery of behavioral health care services. So all of that is work that can be done integrating with Medicaid. And it's really easy to talk about it, and health and housing is the other one. And, and we hear, I can't tell you how many emails I get now. It's like every day, talking about the integration of health and housing and human services. But the part of it that's really exciting and challenging is that it really does require the same kind of work that you've been doing in work support strategies. And that is at the ground level, at the agency level of getting these systems to talk to each other, learning each other's language. I've been working a lot with our housing team, and I'm learning their language, and they're learning my language, and it's really something that really is sort of that same kind of work I think you've been doing, but now we're going to be talking about the delivery of the services themselves and integrating the financing. And it's really, really, I think, the amazing new opportunities as the ACA is here to stay, to be able to have that stability to really focus on that work was a gift to me when I sort of woke up that next day, and I think it's probably the same way that all of you feel.
Thank you very much, Judy. I think particularly for a state's perspective, we're very excited to hear from Jen, who I should have said is now a senior policy analyst at Centron Budget and Policy Priorities with Judy, but until recently she was the associate director over policy and field operations at the Illinois Department of Human Services, so she has a wealth of expertise about that too that we welcome hearing about.
Thank you so much. As we all know, and as we've heard today, the ACA has had a huge impact, not only in providing health insurance coverage to millions of people, but also affecting things across a spectrum of benefits. And one of the places where that is most clearly felt is at the state level. And I know here I'm preaching to the choir. You all are the folks who have been working on ACA implementation and have the gray hairs and higher blood pressure and all the other things to prove what a challenge that has been. And for those of you who have seen me speak on this before, you know that in a slideshow, I use a picture of an atomic explosion to represent the impact that ACA has had on the states. And if anything, I've been accused of that being an understatement and not fully representing how much of a change that has made for the states. But really, the Affordable Care Act represents a seismic shift in how states administer Medicaid as well as other public benefits. But the impact from Medicaid is felt across all states, whether they've expanded coverage or not. The ACA, of course, requires a transition to MAGI budgeting, the requirement to be able to apply online, by phone, in person, through the mail, and also a big transition to a greater reliance on electronic data. Many states still have a lot of caseworkers who are known as the benefits police and who check very carefully to make sure that every single person is eligible, usually through in-person contact and requiring the provision of lots of documents, including pay stubs, birth certificates, and anything else that is possible. But the ACA not only encourages, but mandates a transition to a greater reliance on electronic data, a greater reliance on reasonable compatibility, and not that paper-based thing that we're used to. And of course, the requirement for ex parte redeterminations, for renewals, looking at these electronic sources and only going to the customer for paper documentation if you cannot prove their continuing eligibility electronically. And this is also a fundamental culture shift in how we look at health insurance. A lot of states have successfully created a culture of coverage where it's no longer, are you eligible for Medicaid or not? The concept is more, you are eligible for health insurance. Let's look at what program you're eligible for, whether it's Medicaid, whether it's health insurance subsidies, whatever it may be. And there's also that presumption that you continue to be eligible at a renewal for some sort of program. Let's again just make sure that we fit you into the right bucket. And that's very different than how other human service programs are viewed and very different than how it was in the past. And this greater reliance on electronic data takes away a lot of the paperwork that caseworkers were reliant on in the past and gives them an opportunity to be more of caseworkers and assist the customer. So now let's talk about what has changed in SNAP. Okay, now that we've got that covered, we can move on. At a policy level, not very much at all has changed in SNAP. There are still very fundamental differences between SNAP and Medicaid. Interviews are required for SNAP. And unlike Medicaid, which is more of an on-off program, you're under this threshold, it doesn't matter how much you're under. Of course, SNAP relies on every dollar that you earn to calculate your benefit amount. So they're very, very different programs, but there are a lot of opportunities to interact. And SNAP has been very much impacted by the Affordable Care Act. There's, of course, a high overlap in population served by Medicaid, SNAP, and other human services, which provides that incentive and really, from a customer perspective, mandate to look at these programs across the spectrum and to try to integrate them wherever possible. Many states have had some level of integration between Medicaid and other programs, and in a lot of cases, ACA made it harder. It changed things and almost created a third method of budgeting in addition to traditional Medicaid budgeting, SNAP budgeting, and everything else that's out there. And also the timeframes under the Affordable Care Act made things go very quickly and sometimes jeopardize that integration. But thanks to the enhanced funding, the cost allocation waiver provided at the federal level, a lot of new systems are including or will include SNAP and other human services, and that's a huge opportunity for alignment. But fundamentally, ACA has led to a transformation of the service delivery system, again, in expansion and non-expansion states, with the requirement for telephonic applications, electronic data. You know, really, states had been moving before ACA from this concept of monthly reporting, come into the office, let me look you in the eye, to more of 6-month, 12-month reporting, more of, you know, self-service options like that. And I picture kind of that train was going down the track. The ACA basically strapped a rocket ship to the back of that train and moved it a lot faster, but it's where people were going, and now there are a lot more opportunities. Now, the fact is this transformation in the state operations from the service delivery model, this is here to stay. No matter what some future Supreme Court decision might say, no matter what Congress tries to do, and no matter what that federal election results in, these changes are here to stay, and fundamentally, that's a good thing. So are we done? No, of course not. There's a lot more to do. Has ACA turned out as planned? Well, that's whole, you know, no-touch eligibility, single streamlined application, those things haven't quite come to fruition as envisioned, but fundamentally millions of people have gotten coverage, and that's what it was meant to do. So there's a lot more work to do, but now it's a little bit more about operations and technology in addition to policy. For those of you from the WSS states who were here yesterday for that exercise where you looked at your action plan moving forward, in the past it might have been very policy-oriented, but what I saw yesterday in addition to a few policy changes was a lot about technology changes, about operations, and that's really where things are. And many states have future technology changes planned. They have phase 2 or 3, 4, 5, all the subsequent things that they want to do. And because of the deadlines of ACA, many rushed to, in many cases, adapt to a transfer system instead of having that transfer system adapt to their operations. So many adjustments yet to be made, including getting used to the open enrollment fire drill every year. That has a huge impact on state operations, whether you have a state-based marketplace or not, and states have to become more agile. Most states have figured out using MAGI at the application process, but there's a lot more to look at renewals, at using ex parte renewals, and really at coordinating between SNAP and other programs and Medicaid at changes in research. Lots of opportunities there. There are changes coming at the federal level, as we heard from our partners yesterday. FNS is recognizing the fact that there has been this seismic shift, and I know that they're looking at opportunities to reduce interview requirements, to allow for longer certification periods or heavier reliance on electronic data for historically stable populations like elderly or disabled. But fundamentally, in many states, the first layer is done. The system is in place in some way, and most have gotten through the major backlogs that they experienced as a result of ACA. So it's really time to look at that second layer, to look at change management across the spectrum, from caseworkers all the way up to leadership, and how this new system is going to operate. It's important to solidify business process and training, and to look at accuracy. Great that the applications are processed, but are they done correctly? And customer service. How do we transition from does the system work to does the system work for customers, for those that we served? We have lots of opportunities with the cost allocation waiver being extended through 2018, and states really need to take this opportunity to move to that next step to overcome the change fatigue of the past couple of years. Many feel overwhelmed and some feel kind of defeated. But it's important to take a step back and see how far states have come from pre-ACA, from the beginning of WSS, and where they were, where they are right now. It's been a bumpy road. There have been many challenges of dealing with our vendor partners and all the excitement that they have brought to our lives. And there also has been a lot of resistance at the ground level. I'm sure many caseworkers are still saying, this won't last, we're going to go back to the old way of doing things soon. But they're going to have to realize that that's not the case. But I encourage all of you to really keep your sights on where you want to go and that ultimate vision for customers and for the staff experience. There's so much information out there. There are so many resources right here in this room on states that have struggled and states that have been extremely successful. There have been a lot of successes in BPR, in system changes, in policy. And for those who aren't there yet, don't feel bad about it. Take inspiration that it can be done and that they've overcome those challenges and been successful. The pieces are in place to be successful in transforming this service delivery system. There is funding and a mandate and a deadline. Those are the key elements that can overcome some of the bureaucracy that is fundamentally in place and make changes. And I think that in the end, the second biggest legacy of the Affordable Care Act, beyond the millions of people who have health insurance coverage, will be this transformation of service delivery system impacting multiple programs to the great benefits of the people that we serve.
Thanks very much. We often talk about, in ACA land anyway, about the fundamental shift in insurance and the way it's priced, and this seismic shift in the idea that insurance should be available to everybody with very small differences based on price. But it certainly became clear to me early on in the course of covering things that there was also a seismic shift in approaches to Medicaid, and the idea that, in fact, you should want to sign people up for it as opposed to not want to, and make it easy as opposed to difficult. And this really did represent a potentially game-changing thing in that program, and perhaps in other programs as well. So Olivia has some specific thoughts on that I'll let her speak about, as well as what you've seen in the States and what this could mean for more integration in the future. I'll hand over to her, and then I have some questions for Jen in particular now that we'll get right on to.
Great. Well, I'm Olivia Golden. I'm thrilled to have this chance to talk about the vision after ACA, both with the 100 or so people in the room and the couple hundred on the web. And I'm particularly thrilled. I'm thrilled Louise agreed to moderate and that we have this terrific panel, but also that the audience is health people, human services people, federal people, and private philanthropy. And I'm a big believer that if you're going to make remarks, you should have requests that you want people to do, and I really think that achieving the vision of ACA is going to require participation from all those groups. I would just say that when Louise originally asked me what she wanted from these early remarks, she wanted a framing of a vision, so I want to give you 3 parts to a vision for what health and human services integration after the ACA could involve. And in doing that, I draw both on the recent few years leading the Work Support Strategies Initiative. For those of you on the web who don't know it, there are 6 states, Colorado, Idaho, Illinois, North Carolina, Rhode Island, South Carolina, all represented in this room, who've been working for several years on integrating the enrollment and eligibility side, and other states in the room who are also doing work. But I also draw on a much longer time working on issues of child and family poverty. I think of the ACA as the biggest opportunity in my professional lifetime, which is, I'm an old person, about 35 years, more than that, to make a huge difference in people's lives. But I think that for different reasons, both human services people and health people tend to resist that idea. Human services people sometimes feel left out and exhausted and as though all the attention's gone somewhere else. And health people see the day-to-day obstacles so vividly that it can be hard for them to step back and say, as Jen just did so powerfully, wow, this really is a big deal. So the 3 pieces of the vision that I wanted to lay out. The first I don't have to say very much about because everybody else, particularly most recently Jen, has highlighted it, and that's an opportunity to think about enrollment and retention in the package of these core benefits, Medicaid, SNAP, others, as something that government shouldn't get in the way of, that should be easy, technologically smooth, not burdensome, and people should just get and keep what they deserve and what they need. And that, I think, is the area where the work support strategy states have an extraordinary amount of practical knowledge about what it takes to get there, how it is that you connect technological innovation, financing, policy, business process, how you manage the political dynamics, because I think what Louise just said about it is a game changer to have the ACA be clear that you're supposed to try to enroll people, but there are certainly places around the country where that takes work and skillful framing and leadership by people who care about Medicaid and about low-income people to make happen. So that's number one. Second piece of the vision, which I think both Maria at the beginning and Judy touched on, but let me give you my framing. The big reason that I think of this as the hugest opportunity in my lifetime for low-income people is that once every state expands Medicaid, everybody in this country has the opportunity to get treatment for health and mental health problems in the way that my middle-class friends do now. And I want to note that while the expansion states have the biggest opportunity to achieve that goal, and everybody's got to get there, states that are have not expanded, there is a second set of provisions, the mental health and behavioral health provisions in the ACA and associated legislation, hugely change the circumstances for Medicaid and for those covered in the exchange. And so there is an opportunity in other places too. It's just not as big yet. I often say when people say social determinants of health, which means, as you know, thinking about poverty and nutrition as elements of being healthy, that for me the most important thing right now is the health determinants of social and economic success. That is, right now we have the opportunity to get everybody health care, and we know, and Maria began with this, that not having health treatment for problems that we know how to solve, of which maternal depression is a very vivid example with a lot of data. I've done a lot of work with my colleagues at CLASP at the Urban Institute on that. Not being able to get care for problems that we know how to fix is a big barrier both to low-income people's success in work, in school, and their success as parents. And it's a huge barrier. I come at this from a children's angle to young children's development, because young children whose parent is depressed are going to start out with risks for their cognitive, then their social and their early learning experiences if that depression is untreated. The incidence of depression is way higher for low-income women, and it's typically not treated. So, and I've been engaged now in a number of states where they're just starting the process of thinking about, okay, now we can get everybody health and mental health treatment and have a financing stream. How do we deal with all the practical obstacles to get there? And the one thing I want to say, we'll have time to talk more about barriers in the Q&A. Well, two things I want to say. One is, the experience of the work support strategy states is not directly on this point. You haven't been sitting down saying, you know, how to licensing barriers and reimbursement barriers and a million different practical things. How do we solve them to get a solution? But your experience is very relevant to how would we go about that process? Because you've been, by solving eligibility and enrollment, you've been thinking about how do a million picky details in 2 or 3 or 4 separate systems that no one person understands, how do you come up with a process to solve those things and get to a result? And when I sit in states, I was just in a conversation with New York City and New York State people, I'm very struck that part of what has to happen is that everybody has a little piece of the knowledge, nobody has the whole knowledge, people who know what the problem is don't know even how to frame their questions. The Medicaid director wants to be helpful but has no idea what the problem looks like from the perspective of human services or poverty. So I think we have a huge opportunity to use the skill sets we've developed. What I want to say to the funders in the room is that while government can help, the kind of intensive work bringing people together in a few eager states to do this thinking is really very much suited to private philanthropy. So I think that's a huge opportunity. Last thing I'll say as an element of the vision, I thought about whether to separate this out, but I want to separate it out because I just want to hold it up. Continuity. The fact that once all states are expansion states, this is another reason that's important, it's not only that every person should have access to health care at a point in time, but that the legal and financing framework of the law is about having health care your whole life, from when you're born to when you move to Medicare, when you also have health care just in a different system. And it's interesting, when I say that to health people, they frequently say to me, but it's not working that way, vertical integration is so hard, there's 100 different obstacles. And that's true, but for those of you in the room who are human services people, who've thought about how hard it is to keep somebody on a program for 3 months, I see Shannon nodding about childcare, or what a huge success it is that Head Start keeps eligibility for a year and maybe for more. Just having the financing and the conceptual framework and only practical details in the way is a huge breakthrough. And to me, that's key, because if you think about poor kids, poor parents, poor adults, many of the outcomes we want people to achieve in their lives don't happen in a 3 or 6 month stint. You don't raise a happy and healthy child, children don't grow up, young people don't make a transition to adulthood, adults don't gain skills and work experience in 3 months or in 6 months. So the fact that in the end, in the vision, healthcare offers the single thing that we're committed to making available to people when they have a problem, so that they can build up relationships, perhaps with a doctor or a health center, and have access when a problem that was solved for a while is chronic and comes back, that's a huge opportunity. So to me, those are the parts of the vision. It's hard to get there. We don't have all the solutions, but we do, I think, know a lot about what it would take to get organized to work on those solutions.
Thank you so much. I think Olivia in particular raised a number of issues that I'd like to press her on and ask everybody else to join in on the panel as well. And so the first, I think, really is this question of Medicaid expansion. And I wonder, for all of you, how much you think can be done without Medicaid expansion in the states that don't have it, and to some extent whether this shift in attitude towards Medicaid, that people should be signed up for it if they're eligible rather than presented with a series of hurdles that dissuade them, is in itself a barrier to Medicaid expansion in the states that haven't adopted it. Because certainly from the rhetoric that I've heard, there's a lot of concern about Medicaid being too big, and the idea that you would make it possible to make it even bigger, not just by changing the way eligibility is framed. Is this a program for everybody with a certain income rather than a program for people who categorically fit certain definitions, really does have the potential to be a sticking point for some people who are concerned about it. And so I wonder if perhaps Judy in particular would like to jump in on that, and ways in which integration perhaps has influenced the Medicaid expansion debate.
Yeah, I mean, I think we've been working very, very hard on Medicaid expansion with a number of partner organizations in a lot of states. And what's really been incredible to me is the degree of very well-funded opposition that's out there. And that, you know, we just need to acknowledge that there is this real antipathy to Obamacare, and people that are really dedicated to basically keep some states from expanding. However, I think the good news is that at the end of the day, over time, the states will come around because it's a deal that's too good to leave on the table for them. And I think one of the states that I'm most interested in seeing how things work over the next few months is Louisiana, where this real sort of practical need for the money. It's, you know, this is a deal, this is a lot of money for states. And in Louisiana, they have a governor election this fall, and of course their current governor is totally opposed, but all the candidates have indicated some openness to doing it. The hospitals have come forward and actually put some dollars on the table if it can be done quickly, and they have the biggest hole in their budget so that they might move very quickly. So I think that is really, we need a state like Louisiana, we need a Virginia, I know they're in the room, or, you know, any of those southern states to really sort of break this hole. And then we need, I mean, it's just been so clear to me as we've seen, you know, states like Montana where, there was just an ability to sort of turn around that what got labeled as out-of-state opposition, and it was very, very cool, you know, to sort of see, well, in Montana, we don't like those people coming in from out of state and telling us what to do and going ahead and expanding. So I think that's really the biggest challenge. The degree of opposition is very ideological, but once you get beyond that to the practical, I think you can break through. And you know, in answer to the question, I do think there certainly are things that can be done with the expansion of services and the improvement in options in the Affordable Care Act in states that haven't expanded. But if you look at who's left out, and it is those very low-income adults who don't have a disability that's recognized for the purpose of the Social Security program, many people involved who end up in the criminal justice system because of untreated behavioral health problems. We can't break through to that group until we can get them health care, and the Medicaid expansion is the only way. So I just feel like that has to be kind of number one on our agenda, and then, you know, really show the way in the states that have already expanded to how you do this real service delivery piece.
Well, it sounds as if from what you're saying that the Medicaid expansion opposition is not necessarily premised on a concern that in addition to growing Medicaid, you're also growing other programs that people have concerns over the sides of, such as food stamps.
No, I mean, they certainly have been pointing out enrollment growth in states that goes beyond the projections, and you know, to us, that of course is good news that, you know, people have been able to enroll and come in, and it has gone quicker in many states. But again, that's just scare tactics as far as I'm concerned. I think fundamentally it's going to have to come through this continued grassroots work and overcoming that opposition and getting the real practical other stakeholders, hospitals. Hospitals have been there. I mean, we've seen the health of hospitals in the expansion states compared to those in the non-expansion states is just enormously different. So I think at the end of the day, those very practical concerns will overcome the political. But the thing that we all need to understand is it's very real and it's very well funded. And that to me was not really expected.
Well, let me turn this on its head a little bit. On the one hand, there is a potential for Medicaid expansion to be hampered by its connection to other services, but I think perhaps I'd like to ask Jen about this. There's also, for people who are trying to make these programs more aligned with each other, a more fundamental difference between them in the way that they assess eligibility, in the very basic way that they work, that I wonder if all the technological advantages and improvements in the world aren't going to be able to overcome. But I think you've seen a little bit about this on the ground, and perhaps you could tell us a little more.
Sure. It's definitely challenging when the policies are different and when there are fundamental requirements, such as, of course, the interview for SNAP and not for Medicaid. But technology and specifically rules engines have provided a lot of opportunities where it's a tremendous investment up front, but once all of those complex rules are entered into a system, the caseworkers can enter, for example, income, the different types of income, and the rules engine will decide what should I count for SNAP, what should I count for Medicaid. And that helps a lot. Of course, we don't want to turn caseworkers into automatons who are just keying things in. They still have to understand the complex policies, and they still are difficult, especially in states that have been bold and tried to go beyond just SNAP, Medicaid, and TANF and include child care or LIHEAP. You're introducing more and more complexity, but I think that technology offers an opportunity to really have those things programmed in and allow the caseworkers to spend more time working with a family than doing complex calculations in their head in the background.
Maria seems to be agreeing with part of this, and I also have a question for her that I've been dying to ask anybody from the HS side of HHS for pretty much the entire time that the ACA has been dominating the conversation. And what I always wonder is whether folks who do work for the HS side of HHS feel as though the focus on the H has been beneficial to them because they've been able to quietly sort of go about doing things perhaps outside of the spotlight, or if it really has sucked the energy out, or indeed if there have been some sort of benefit from the ACA that you've seen trickle over that perhaps we haven't been paying attention to.
Well, so I think there's definitely a bandwidth issue. I mean, and there's a lot of folks here from states, so I don't need to say that to you. You know, there's a limit to what people can do. And I think both the practical and political issues around ACA implementation really did kind of keep people busy. And I think that's part of the motivation for the A87 waiver and giving people another 3 years to kind of step back. But I also think now that hopefully many people are able to take a breather, it does give us a different perspective. And I think there's a couple of very beneficial things that ACA has done. One thing is I think the focus on health has gotten us refocused on prevention. I think the concept of health not being something that kind of falls out of the sky, your health today has something to do with kind of the trajectory that you brought with it. So too do some of the challenges and strengths that our families bring to our programs. They have a history, and our ability to focus on upstream prevention is really important, and I think the ACA has kind of given us that. I think the other thing that it's given us is a focus on the need to attend to some of these very kind of techie things like rules engines, which will be in this new library that we're creating. And just in general to focus on the eligibility and enrollment process and create kind of a seamless system that provides the services that people are eligible for. I think that has also been a benefit to us.
Can I add to that one? As I think about the bandwidth issues, both from my life when I was at ACF and from the experience with state agencies now, and I share Maria's perspective about the opportunities. I do think that where Medicaid agencies have been totally overwhelmed, in some of the WSS states, the human services agencies have found a way to treat that as an opportunity by tying their own goals to those same insane deadlines. So that's really what it means to buy into a shared integrated eligibility system. I know Jen may want to comment from Illinois, but Rhode Island, North Carolina, it means you're tying yourself, Idaho, you're tying yourself to that same craziness, but you may be using it to get things done that you need to get done and using the forcing power of a deadline and a great deal of attention. And so I think that's been an important strategy. In places that couldn't take on that strategy, I think Maria's right about the next step. But the other thing I wanted to add is that the other thing that I think is a challenge on the human services side, it's easy for us to say, oh, those health people have been distracted. But of course, we've been distracted too, right? Human services agencies are dealing with their own crises. But second, we're trying to get out of what I think of as certainly decades, perhaps centuries, of habits of just assuming that either nobody in the families we dealt with had access to health or mental health services, or maybe just children did. So the child welfare system, where I've spent a lot of time, is a vivid example. Child welfare systems around the country have built, yes, everybody needs drug treatment and mental health, but we don't have any money for that, so we're going to go create small family support programs. And then we're going to go see if the ACA can fund those small programs, as opposed to what we really need to do is start realizing that the opportunity to change the basic systems and get parents that treatment. So there's a lot of reshaping thinking on the human services side, too. It isn't just the health world's been busy and has been brushing us off.
Well, we've talked a lot about the integration of programs horizontally and particularly within the states, but particularly since I think your goal is to be looking forward, one of the things, and we should throw this open to the room very shortly, is what in particular you think the federal government could do better and what is being done already to make sure that the perhaps third seismic shift of the Affordable Care Act is realized. And that's really the idea that you don't fall off a cliff of support at a certain point. You become ineligible for Medicaid perhaps because of growth in your income, but you are in fact eligible for subsidized coverage through the exchange, at least until you hit 400% of FPL. And Jen made this point to me last night, and I think it's a very interesting one. But I think both what she and Judy perhaps have seen, and I'm sure all of you have seen as well, is that perhaps the system, both at healthcare.gov, that looks like it's going to continue to serve the majority of states for the foreseeable future, especially after King, but also to some extent in the states as well. What you've seen is that perhaps the system is not always as seamless as it could be when people are moving between Medicaid and subsidized health insurance, or indeed back and forth, possibly at various points in a single year. So if you two in particular, but everybody up here wants to talk a little bit about that for a minute, that would be great. And then let's throw it open to you guys.
I mean, I think it's huge. I think the states that have, the states like Idaho. I've loved listening to how they, kind of came in later and built an integrated system. I think they have a lot to teach us in terms of that vertical integration. But, we always knew it would be a challenge, but I think the fact that the rollout of healthcare.gov was so hard that they never expected to be administering programs for, well over 35 states, has really put us in a place where there is a ton of work to do to really build what is now a sort of national public benefit program. And I would say that at the beginning, there almost wasn't really even a recognition that this is a public benefit program, right? We're delivering subsidies, we're delivering them through the tax code. That is really hard. It's really hard for people to get their heads around what is a refundable, advanceable credit. How do you give people a monthly benefit that's built on what they earn at the end of the year when they file their taxes? I mean, the number of challenges that are there, and then aligning with a Medicaid program with current income, using current income. It's really, really hard, including the way the states had to totally fundamentally change how they look at income to adapt to a tax definition of income in households. So I think, I could go on, I'm not, but I could go on forever on the challenges that we've seen. But I think, you stated it, Louise, the real need, we need to keep our eye on that prize, is that you need to move from one program to the other. But there's sort of a landmine there that is even a little different. It's not that you might lose coverage, but you could end up, if you end up in both programs and you could have been in Medicaid, you may have to pay some money back. So, I mean, the coordination and getting those transitions right in terms of the dates so that people aren't enrolled in both programs is just enormous, and it's much bigger than I think anybody anticipated. And I think it's just going to be years till we totally get it right. Resources are thin. We're using private contractors for a lot of the work, very production-oriented, different contractors, call centers, eligibility contractors, making all that work. I know, the current leadership is, we meet all the time. They're very invested in meeting with the outside stakeholders, but there's a lot. There's a lot. And the tax implications are probably the biggest part of that, and getting people's heads around that.
I think the vertical integration piece is definitely the next frontier that we've got to be looking at. The horizontal integration, we know what needs to be done. We know what the obstacles are. They're not easy to overcome, but some states have succeeded. We better understand that. The vertical integration piece is something that now people are just having a little more capacity to look into. Obviously, it differs a lot between states that interact with the FFM and states that have a state-based marketplace. But even in those states with SBMs, I'm surprised to learn how many difficulties they're experiencing as well on vertical integration. And I think, as was said earlier, the people in this room are the exact right people to break down those barriers. This is a different set of conflicting rules, but it's the same principle that you all have been struggling with for years. And I think that with these minds putting their heads together and working on this over the next number of years, we're going to really streamline that more and better serve the individuals that we're seeking to serve.
So I think one of the questions, thank you, that was put to you yesterday was what you would want the next administration to know. And obviously, to do that, you're going to have to imagine all of the possibilities, all 21 of them right now from people who are running for president, about what that administration might look like. And I think perhaps if you're trying to game that out, it might resemble something of our planning for a King v. Burwell decision. You sort of, at a certain point, just the possibilities become limitless and you can't handle them, and you decide to just wait and see what happens because it's easier. But you obviously do have to start thinking about this now as well. So perhaps if that wants to be one of the focus of the questions, and if we want to get the mic around to anybody who wants to ask one, and I'll grab cards if there are some from folks who've submitted them online. If you desperately want to get one in online now, events@clasp.org is the best way of winging it over. But let's see who in the room wants to weigh in.
Virginia me now. So there's an entirely different set of states that have been working on testing new models for integration of health and human service programs in their payment and delivery system reforms, and are running up against their own set of barriers. And being a person who works with a lot of states, I think in terms of, how do we push the spread? How do we get beyond our silos, both in terms of the states who have expertise and who are thinking about this in different ways, and elevate that so there's more conversation and experience sharing, both within HHS, the people who are sort of managing the work on the SIM initiative, and the people who are managing and aware of more of this effort in terms of both the eligibility work, but even familiar with ways to sort of make these programs work a little better together.
It's a really good question. If I could tack one on as well, and perhaps ask Maria if she wants to weigh in on it. Is there anything that you think can be done to make it easier for people to move between states as well? It seems as if, particularly if you have very sharp cliffs between some in terms of what they are making available, but also the reality of people's lives that they do move around, particularly in certain parts of the country where state borders are very close to each other and close to population centers. That would seem to be one of the other integration challenges that you have ahead of you in a system that, it's at a fourth seismic shift for the ACA here, really did attempt to impose a federal overview policy on the entire country for the first time.
So on the cross-state piece, I'll just say this is, I think this is an issue that we've seen in little pockets in particular areas. So for example, something that's gotten some attention recently is the ACA extended coverage to youth aging out of foster care to 26, but there are some concerns about if youth age out of foster care in one state and they go to college or get a job in another state, how will that coverage follow them or not? And it turns out to be a very complicated issue to try to sort that through. So I think that's, you're right to point that out as an issue. I don't have a neat solution for it except to say that that is a real focus, I think, for conversation. I do think there is, I think we recognize the silos of excellence. I've spent a fair amount of time working on them within ACF, and then between ACF and other parts of HHS and outside. And I guess what I would say is, maybe I'm too much of an optimist, but I do think that the joint opportunities and challenges of ACA have given people a common focus. So it's given us a context to have the conversation about a lot of things, about, for example, the need to get our rules in order, which frankly we had the need to worry about coordinating certification and eligibility and other timelines. That existed pre-ACA. This ACA just kind of raised the stakes and I think raised the visibility of that conversation. I think the same thing goes for the technology piece. We've needed a shared eligibility and the need to ask people over and over again for their pay stubs or their birth certificates or whatever, that existed before the ACA. But I think the need to solve that problem has been kind of elevated again. And the resources, frankly, to solve that, while bandwidth is a problem, I think some of the resources that come with the 90-10 funding and some of the resources that have come from the philanthropic community and elsewhere, just some of the focus again has also been. So I think that, I am optimistic. I see a lot more people gathering around the table to solve these problems, at least within ACF and then more broadly in HHS and elsewhere. So,
optimistic beyond this administration.
Oh yeah.
Can I add something?
Well,
I'm sorry.
I'll just say beyond this administration, I mean, I really do think that the question of integrated services and information, there are a lot of arguments for it. And I think they cross the political spectrum. Now, my experience is almost all in the state of Wisconsin. I've worked very closely with 4 governors, 3 Republicans and 1 Democratic administration. And, you can focus on the need for accountability and reducing waste, fraud, and abuse, or you can focus on the need for wraparound services and making sure that everybody gets what they're eligible for. Everybody getting what they're eligible for and nobody getting what they're not eligible for is 2 different ways of saying the same thing. They both require the left hand to know what the right hand is doing. We have limited resources and people are right to ask us to be accountable for the use of those resources and for the outcomes that we're producing. And that's good both for the taxpayer and that's good for the individuals and families that we're serving. We should be using the limited resources we have in the best way that we can. And so I have spent a fair amount of time talking with, Republican staff on the Ways and Means Committee. They may frame this, they may look at this elephant from a slightly different angle, but I think we share very much the sense of the infrastructure that we need and what we ought to be able to do. We need to be able to account to the families that we serve and the folks who finance those services, who are often largely the same, but they're not totally overlapping, for what we're doing. And we need to be making better policy and running our programs in the best way possible. So
I wanted to add a couple of thoughts about Alice's question, which as I heard it was, people are working on innovation across health and human services with different slants from different angles. How do we build as much momentum as possible? And I would say a couple things. The first thing is that it is incredibly hard, and it takes a long time, right? 5 years of work so far on the work support strategies enrollment piece in 6 states. So to some degree, the idea that every initiative should be about everything, I think, is not right. In other words, I think the likelihood of creating substantial, serious change that is then useful to others does come in part from focusing. And so to the extent that some of the things I laid out in my vision, or Jen did, or Judy did, or Maria did, are persuasive and a lot of people want to work on them, then you have something that you could get lots of people to do. But if in fact people have a bunch of different priorities, I think sometimes you learn best from a bunch of focused ones. But if I were to think about both what might bring them together over time and what might create continuity across administrations, I think about a couple things. I do think about measures. We had this conversation yesterday. What are measures people could be accountable for? We had that great conversation that Pam and the Urban Institute Evaluation team led about the fact that in the 6 WSS states, you can now see in most of them increases in the share of people jointly eligible for SNAP and Medicaid who are actually receiving them both. And so we had this conversation about, could you use that measure to drive the work on the first priority, on the enrollment side? And I think there's a variety of possibilities of measures to drive the treatment side. And I think it's hugely important in this state where I was in the conversation, all the measures they were thinking about for their contracts with providers were all about, cost savings, integrated services, and I think it was Oregon that was there sharing experience, and they said, but you have to, if what you want is for everybody to get depression treatment who needs it, you have to ask for that as a measure. So in some ways, I think that's a strategy for driving innovations that will be focused. And there are many others, but I won't take the time to list them.
I'm told that we're coming up to time for closing thoughts, and I apologize because you've heard a lot from us and we still haven't heard that much from you. So does anybody have one question they can just shout out that they would like to be the focus of people's closing thoughts? But very, very succinct.
Thank you. Maybe next year. The next president and the next Congress, the recent actual report of CMS 2014 that came out in June estimated that GDP, healthcare spending as a percent of GDP is going to rocket to 25% by 2040. How do you afford what you're offering? How do you bend the cost curve? Second, we talk about obligations of government to people. What, if any, obligations do people have to society and to government?
I think that's an excellent question. I'm going to just give it to Judy quickly to answer first, partly because I think that there is a very real tension between Medicaid expansion at any price and traditional Medicaid advocates who want it to be a certain way, and the reality that there are certain states that are not going to expand it unless they get to do it in a different way. They want to change Medicaid, and they represent a very large number of states in the country, possibly yours among them.
Yeah, no, I think, there needs to be some flexibility. I'm not one to say we'll never do a Medicaid waiver, but I think that Maria and then Olivia just really sort of hit on kind of what I think are two parts of the answer. Number one is that a lot of what we're talking about is making government more accountable by not duplicating, by not being redundant, by making services work more effectively so that they're paired together, because, and that all comes from the social determinants of health, which is that healthcare on its own. My favorite example that goes back well to my state days was, trying to make the case for better case management for kids by saying, okay, when the kid with lead poisoning comes to the hospital, it's really important that Medicaid help pay for the relocation, right? Because that's got to be part of the health care. Kids with asthma, you can just go on and have a million. So I do think there's a case to be made that what we're really talking about, and I think Maria just made it well, is accountability and better government. And that, the research goes both ways on are we going to spend less, but we certainly have been seeing some wonderful research that Bob Greenstein referred to yesterday about the longitudinal impact of having people having coverage in terms of earnings and contribution to tax. So I think that's the case we need to make to overcome, the opposition and to show this really does pay over time.
So, I was going to just ask Jen and Maria whether you think you can bend the cost curve through simply better management and better government, and whether you can make the case to people by focusing on different ends of the elephant, as I think Maria was pointing out, or whether there's something more fundamental that you need to look at.
I'd say we have good evidence of specific things, investments we can make that pay dividends. And the challenge is to get beyond just saying more of everything is what we need, because we can't afford that. And we need to know more of what. And doing that requires, rolling up our sleeves. And then it requires the data and an openness to evaluating what works and what doesn't.
I think in a lot of these conversations, I like to twist things, that when people talk about how many people are on Medicaid, when people talk about how many people aren't paying federal income taxes, I don't think it's on that person. Many of those people are working full-time, are engaged in activities, or have barriers that prevent them. So yes, I think we'd all like to see fewer people on Medicaid, not because the state chose not to expand, but because they're earning enough. They are working and getting health insurance through their employer. And I think if we focus more on that, that will have more success, and that'll reduce government spending. And an initial way to support them in that effort is to provide those benefits now while they need it and while they're entitled to them.
And Olivia.
Well, I wanted to tell a story to answer how I think about the second question, which was people's obligations to government, because I think about it as people's obligations to their families and their work, which then also contribute to government. And it's interesting because the recent bipartisan reauthorization in Congress of the Child Care and Development Block Grant takes that approach very explicitly, right? It says we should be providing this in a more continuous way because that enables parents to raise their kids and it enables people to work. But the story I often tell, I ran the Child Welfare Agency in the District of Columbia for 3 years, and there were many tragedies that you see when you do that. And the deepest tragedy, the thing that I found made me saddest was when somebody, a mom who had a substance abuse or a mental health problem, was just desperately trying to meet her obligations to her child, right? She didn't think of it as her obligation to government. She thought of it as her obligation to her child, to raise her child. But she was in the grip of a chronic illness. She couldn't beat herself. And so sometimes for several years, a mom would be, whenever she had a crisis, leaving the baby with the grandmother, the aunt, whoever. But eventually that person would get sick of it. And eventually that child would come into care. And I used to think we could have prevented the trauma for the mother, the trauma for the child, the long-run outcomes, the public dollars, if only we had had mental health or substance abuse treatment available. It wasn't that that mother didn't want to do it. It was that she was, as I say, any of my friends who find themselves in that situation do go to the doctor and get treatment. So I think of access to basic health, mental health benefits as a way of ensuring that people can achieve their obligations to themselves, to their families, to their work, and to government, and that it's a means to that goal.
It sounds as if you have a diverse array of ideas about how to work with the framework as it's set out for you right now with the Affordable Care Act, and that perhaps if 2 years from now the framework has changed very differently, or in fact if it's staying almost exactly as it is with minor changes, you'll certainly be very equipped to do that, at which point you should certainly feel free to call me and tell me what you're doing at any time, because I'll find that very interesting. But it's been a fascinating conversation. Thank you for letting me be a part of it. Thank you for being a part of it. And I think you're all released to get on to your next session, or in fact.
Our next thing is, I think, lunch.
There you go. You're all released for lunch.